Hello, everyone, and welcome to Gladney University. We are so excited that you're with us today. My name is Jennifer Lanter, and I'm the Vice President of Communications and Education for Gladney. And it's so exciting to see so many people logging on to our webinar today. I'm very excited about our topic, which is perinatal mood anxiety disorders, recognizing risk factors for screening symptoms and referring for treatment. I think this is an extremely important topic for families and for our communities. I'm really excited about our speaker today. Her name is Lindsay Minton, and she is a licensed marriage and family therapist from Knoxville, Tennessee. I had the pleasure of talking to her before we got started today, and she's delightful, full of knowledge, and I think she's going to blow us away. Also, I want you guys to know that you can ask any questions during this. Just raise your hand, turn your camera on and raise your hand, and I will unmute you, or you can put your questions in the chat feature, and I will make sure that Lindsay gets to see those questions. We love to hear from you, so please keep those coming. Also want to let you know that a few little housekeeping things is after the end of this presentation, if you will please just click on the link that you will see that pops up, and that will take you to the form that you fill out for your CEUs. If for some reason that form doesn't pop up, then you will very shortly get an email from Gladney, and you can fill out your form there to receive your CEUs. Please give us 7 to 10 business days to complete that action, and you will receive your CEU to the email that you registered with. So if you have any questions, please let us know, and I'm excited to introduce Lindsay. Lindsay, thank you for joining us today.
Thank you. It's good to be here with all of you. I can see some of y'all are hiding out, which I understand. And so we have a lot to talk about, a lot to cover today. But yeah, I am a marriage and family therapist. I live in Knoxville. I have one son who's 5 years old and a husband named Eric. And we have a pug who lives with us, and she's a lot of fun. So I initially got interested in perinatal mood and anxiety disorders after I had a son. So sometimes I'm a little bit of a know-it-all and sort of just thought like, yeah, this is going to be a hard transition. But then once it happened, I was like, whoa, that is a lot to take on. So I don't have a real dramatic story of illness and recovery, but just became interested as I started to realize all the huge shifts that are happening in my life as I became a first-time parent. And so I started looking into how I could be more assistance to others, kind of going through the same transition. So I was already a marriage and family therapist, but wanted to just add that specialty of helping families in transition, helping people who found themselves pregnant kind of navigate those waters a little bit. So we will talk through that, and I will pull up my slides so that we can get started. But I'm excited to share this information with you all. It's really important to me, and I hope will be important to you. And the more people who kind of work with new families, with women who find themselves pregnant that have some of this information, the better, because it is very important. So I'll use the word or the acronym PMADS sometimes throughout this, just because it's a little shorter than saying perinatal mood and anxiety disorders. I can't see all of y'all to raise your hand, but how many of y'all have heard of postpartum depression? Most people have, but we try to expand to actually talk about PMADS as the full spectrum of disorders that can pop up during the pregnancy and the entire first year postpartum. So we sometimes have this limited knowledge generally of postpartum depression. There's a mom who maybe doesn't feel close to her kid. Maybe she's crying a lot. That's postpartum depression. Probably, but it's a much bigger picture. So I wanted to give you all some information about the full spectrum of disorders that you can kind of look out for, just because it's helpful to have a more broad understanding. So when we talk about PMADS, it's mood and anxiety disorders anytime during the perinatal period. So that's anytime during pregnancy, anytime up to the first year postpartum. So those can be like listed on this slide: depression. We can find bipolar disorder pop up then, postpartum anxiety, panic, or obsessive compulsive disorder. We can find postpartum post-traumatic stress syndrome at this point. We can also see postpartum psychosis. So there's a really broad range, and I'll give you some more detail about what each one of those disorders looks like kind of as we move forward. But I want to make sure we have kind of a good background. And why would we bother talking about it? Because it's not a small problem. They're very common. It's the #1 medical complication related to childbearing. I think that's just in our country. It might be everywhere, probably worldwide. I'll have to go back and look at that study, but it's a large problem that happens. So if you think about, we screen kind of everybody universally for gestational diabetes, and yet that does not happen nearly as often as a postpartum mood or anxiety disorder. And so it depends on the study that you look at, depending on what cutoffs they use to decide whether or not someone fell into this category. But typically 1 in 7 women develop some kind of significant depression or anxiety following childbirth. Some studies show 1 in 5 if they have like a little bit lower threshold for cutting that off. So it's incredibly common, and so it's worth talking about, because this isn't something that's just here or there. The more you start talking about it, the more you'll find people say, "Oh yeah, me too," or "Oh yeah, my friend had that," or something like that. So it's really common. So it's worth spending a bit of time kind of learning more about. When we do find the presence of PMADS, there are risks to mom, baby, to the whole family unit. And so we don't ever want a mom to feel bad that she's hurting her baby. And we want to be very supportive to families that are experiencing these disorders, but there are very real risks if they're not treated. There are developmental delays that are possible for baby if baby's not maybe getting interacted with to the degree that would be normal for an infant. We can have risks to just the relationship between mom and baby, to mom and any partners in the home. We can have job loss. We can have all kinds of, social impacts if mom's not feeling okay. And then we do have some cases of, babies being harmed physically, being killed, moms killing themselves. So suicide is a very real risk. So we want to pay attention. A lot of, when you kind of think of postpartum depression, sometimes we picture more of these really extreme cases where a mom has killed her children and killed herself. And that is very rare. And most of the time, that's actually postpartum psychosis that is presenting itself. But it is a very real threat. So the more we can know about it, the better. And the more we can help a mom who's significantly depressed realize that she could get better, then we're going to eliminate a lot of unnecessary deaths. So that's kind of the most extreme reason we want to talk about it. But on the full spectrum, like, it's a big deal. It does have impacts. It's expensive too. There's some studies about just how much money we have to then spend to kind of deal with the different kind of cascading effects if we don't have that early good connection between parents and their baby. So it's important to talk about for all of those reasons. And it will not, oh, there we go. I'll click for slides. My arrow wasn't working. So again, when we're talking about the full spectrum, a lot of us are familiar with what is really called the baby blues. And this is not postpartum depression. It is not a disorder. It's just an incredibly common syndrome that kind of happens usually just in the days following a birth. And so it's going to affect around 60 to 80% of new moms. And so if any of you out there have birthed children, many of you probably would be able to say, like, yeah, I remember something like that, just really not feeling like yourself. Maybe a lot of crying, possibly, sometimes just feeling really irritable or angry. It can just look like just emotional instability. So you're sort of like, I feel fine. All of a sudden, I don't know what's going on. And it's kind of just up and down, a little bit all over the place. That's likely due to some hormonal changes that are happening post-birth as your body kind of readjusts to everything that has just happened. And it's going to last just for about 2 days to 2 weeks. So if it's lasting beyond that, that's when we want to start looking at, well, maybe there's actually a disorder happening. Maybe there's actually postpartum depression happening. So if you're in a situation and for 2 days to 2 weeks, you're feeling this way, very normal, happens to just about everybody. And so you just want to kind of ride it out, right? Get some good support, make sure you have help around the house. But these are things that are going to kind of clear up themselves. If they don't clear up, that's when we want to start figuring out what we can do next and kind of how we need to intervene, for sure. So if you're interacting with new moms and you're seeing some of these symptoms, then you want to start thinking about postpartum depression. So I know y'all are in probably a range of professions that are here on the call. So some of you all are therapists, some of you all might be seeing people in the medical setting, some of you all are interacting through case management and other kinds of things. So you have all kinds of different roles with people, but So I don't want to repeat this for those of y'all that are familiar with diagnosing things like depression, but a lot of postpartum depression looks similar to any kind of depression, but it's showing up during the postpartum period. But you're going to see a down mood. You're going to see maybe not being interested or not able to experience joy or pleasure with things. So we have this expectation that a new mom is going to be really excited to be with her baby and all of that. Well, with postpartum depression, you're not going to really see that. There's not this interest or this is so much fun. Now, for many people who have babies, not everything that you do is going to be a ton of fun. So it's normal to not love every midnight, feeding and changing of diapers and things like that. But if in general, we can't get any pleasure from anything of like, I used to love watching TV shows and now it's just really flat to me, then we want to start thinking about possibility of postpartum depression. Maybe sleeping too much, too little, maybe not being able to fall asleep even when the baby is sleeping well. Feeling really restless, or maybe feeling super slowed down, like it's just really hard to move, a lot of fatigue, feelings of worthlessness or guilt. You might find some difficulty concentrating. We can have these thoughts of death of like, I just wish I wasn't here. You might hear from moms thinking like, my baby would be better off without me. That would definitely be a sign of postpartum depression. And you're going to see other mood changes, maybe irritability or anger. The specific thing for postpartum depression versus just depression at some other time in life is maybe this feeling of disconnect from the baby. They're going to have some complicated thoughts about possibly their role as a mom, and maybe feeling like they're failing at that. These worthlessness, guilt feelings are going to maybe be a little bit connected to that kind of theme. So those are some things.
Hey, Lindsay.
Yeah.
This is Jennifer. Sorry to interrupt you. Some people are saying they can't hear you very well. Can you speak up a little bit louder?
Sure. Yeah, I'll scoot a little closer too.
Oh, thanks.
Yeah. All right. So that's postpartum depression. So let's look at the next slide, postpartum anxiety. And let me know if that volume is not good, and I'll try again. But with postpartum anxiety, again, it's a lot like anxiety in the regular life where we're worrying about a lot of different things. But in specific to postpartum period, you're going to see a lot of fear and stress about the baby's safety or about the health of mom or baby. So you might see a mom who constantly sort of feels like she's getting some kind of illness or is dying. You may see things where she just is constantly worried. Is baby eating enough, sleeping enough? Is baby's diaper going to give a rash? Like just kind of a lot of different things to worry about. There are a lot of things to worry about with a new baby, but with postpartum anxiety, you're going to find that that's difficult to control. There's going to be kind of this sense that there's restlessness, fatigue, it's hard to concentrate, and it doesn't resolve or get better. So of course, every new parent is going to have some fears, but once we develop kind of this interference with regular life, that's when we might go ahead and move on to calling it postpartum anxiety. So one way you might be able to tell this is somebody might not want somebody else to watch their baby. They may have difficulty even letting baby sleep and them going to sleep as well because they have some fears. And so they're sort of watching baby and not sure if they should leave baby alone. So that's what you might kind of see with postpartum anxiety. Then we move into postpartum panic, which again is going to look like regular panic disorder, but it's happening postpartum. So extreme anxiety, this kind of overwhelming sense of doom, danger, that something bad is going to happen. This person might feel like they're dying, kind of going crazy, losing control, and you're going to see a lot of physical symptoms. And so this might often go hand in hand with a postpartum anxiety diagnosis. So that's something to watch out for. And you can kind of see a list of those physical symptoms that they might express during that time. We can also have obsessive compulsive disorder with onset postpartum. And so that's something that maybe we haven't thought about or haven't paid attention to. So with obsessive compulsive disorder, we have obsessions, which are going to be these recurrent, very persistent thoughts that are seen as distressing and intrusive. So meaning that they're kind of coming from outside, that they're not you don't really want these things or want to have these thoughts, but you kind of can't get rid of them. And so they keep showing up, they stick around, and then you kind of make attempts to get rid of them, to try to ignore them, get rid of them, replace them with other thoughts. And so compulsions are one way to get rid of them. So your picture generally with OCD might be that somebody has some fear of getting sick, and so they need to wash their hands for a certain length of time. Now that's all that we all do all of the time. So we can kind of understand that connection, or how our brains can kind of do that to us, that we have a certain thing we're trying to prevent. And so we come up with some kind of practice to prevent it. But the thing that happens with postpartum women is that they have these intrusive thoughts that usually are often about harm coming to, again, themselves or the baby or other people that they care about. And they may actually have intrusive thoughts or pictures of this harm happening. So I don't like to give too many examples, because if you are in that world, you don't need more fodder for your imagination, but you might see yourself hurting your baby. People specifically are afraid often of heights. They may picture themselves dropping their baby from a large height. People have a lot of fear around water and around sharp objects. So I worked with a woman that specifically would think about knives, and she felt like she wouldn't be able to control her body, that she might pick up that knife and then harm somebody else. And so in this world, moms don't often trust themselves. They're often filled with a lot of shame. And so you can imagine they don't really want to tell anybody. If you had this baby whom you loved, and then were imagining yourself causing harm to that baby, you probably would have a lot of shame, and you don't want anybody to know about it. So these women often suffer in silence for a long time, because they don't know that this is kind of a normal but not normal response, right? There's nothing wrong with them. They're not bad moms. They don't actually want to hurt their babies. They're likely not going to hurt their babies. These women really don't act out these thoughts or fears. And yet they want to keep silent because they don't know. So it's great to know about this, especially in all of your roles. If you're encountering a mom who does disclose this, it's really helpful to know that this is kind of a normal disorder. And so we can respond with kind of compassion of like, of course you're a good mom, and of course you're not going to hurt your baby, and we can help, right? So you don't have to immediately get emergency services and DCS and get her sort of criminalized for these thoughts. Like, they're just thoughts. And so it can be helpful to kind of be aware of this existing. Postpartum post-traumatic stress disorder. So obviously a lot can happen in childbearing, throughout pregnancy and postpartum, or throughout pregnancy and birth. And so there's just a few possible traumas that I listed here. I'm sure that if we threw it out to the crowd, you guys could mention a lot of things. Some of you all may have had traumatic births. And it's really just in the eye of the beholder. It's your experience. If it felt traumatic to you, then it counts. It may be things like an emergency C-section, any kind of postpartum hemorrhage. That's scary. Sometimes people see themselves bleeding a lot and know that they may have the possibility of dying, and that's obviously terrible. If you birth a baby who is in distress or sent to the NICU, if you have preeclampsia, some other kind of significant health risk to you or your baby, anything like that could end up leaving you with some post-traumatic stress. So survivors of abuse might also be re-traumatized. There are a lot of kind of triggering things that happen in childbirth, this loss of control and various other things that can maybe re-traumatize someone who was previously abused. What you would see in terms of symptoms, things like re-experiencing the event, reliving it, having dreams, memories, wanting to avoid. And so a lot of these people will not go for follow-up medical care because they don't want to go back and see that physician or medical provider that they encountered during the birth, or they don't want to be back in the hospital or things like that. So they may avoid follow-up and things like that. There's a lot of physiological arousal. So feeling on edge, tense, worried, not able to sleep, things like that. And so specific to postpartum, a lot of women have an experience of just really feeling uncared for during labor and delivery, feeling ignored, feeling abandoned, powerless, invisible, just like not feeling like they really had somebody on their side there, not feeling listened to sometimes. And so those things can really complicate that birth experience. And they may just have some things they really need to talk through afterward to be able to reduce some of those physical symptoms of the postpartum stress. A lot of times people are told this was a bad experience, but you have a healthy baby, so you should be happy, which can really discount and invalidate the feelings of that person who already was feeling sort of ignored during the process. And so one thing you all can do too as caretakers of women and families is to remind them, like, it's okay to have those hurt feelings. Yeah, you have a healthy baby and you're healthy, and that is great, but it's okay that it was a bad experience for you, and there's space to kind of talk about that. So that's something to keep in mind. Postpartum bipolar disorder is going to have those combinations of the major depression that we already talked about, along with some kind of manic or hypomanic episode. And so mania have some things listed here, but there's this kind of inflated sense of self. Maybe we don't need sleep. You might encounter somebody who's speaking really loudly, rapidly. They're just getting all this stuff done, and they're just kind of moving all around, a lot of racing thoughts and restlessness and things like that. So that's something to pay attention to. That could possibly be a medical emergency if they're in that manic state, depending on kind of what it looks like, just because people aren't themselves. And so they may make decisions or things that would be risky or would not be in line with what they would do when they're really feeling like themselves. So that's something that we can also look out for. Postpartum psychosis, again, is pretty rare, but it may be the one that makes the headlines most often when you see these stories. It's usually 1 or 2 in every 1,000 women who've given birth, but it is the most dangerous. So this one is always an emergency. And so if you do encounter someone that you think is encountering postpartum psychosis, it's definitely a 911 call, an emergency room call, a crisis hotline call. It's definitely an emergency. There is a 5% suicide risk. 4.5% of these women will kill their infant. And so that's too high, right? 1% is too high. So we want to make sure that we can pay attention to this. So again, these are not bad people. They're not terrible moms. They are very ill, and they are not aware of what they're doing at this point. It most often occurs within the first 2 weeks postpartum, though people do report it later. And it's usually something that's going to be seen by friends, family, other people around. The person experiencing it may not be aware. Some of the symptoms you can kind of see listed there, but delusions, hallucinations, like very just disoriented, not yourself, really just not connected to reality. But you might see some normal bits in between these not normal spaces. But if you're talking to somebody and they just don't seem like themselves, don't seem in touch with reality, this would be something to definitely get further evaluation for that. The difference between the postpartum psychosis and the obsessive compulsive is going to be that these people don't recognize these thoughts as intrusive or particularly distressing. So if I was experiencing the psychosis, I may be thinking I need to harm my baby because my baby is evil. Right? And I'm not disturbed by that. I'm just thinking like, okay, sure. Whereas with OCD, I'm having that thought, but very distressed and confused. Like, why would I do that? That doesn't make any sense. So that's a little bit of how to differentiate it. You don't have to diagnose or differentiate any of this stuff yourself. If you are a therapist and that's within your scope, great. If you're not, there are plenty of people that you can kind of call or refer to, but I just want to give you a picture of kind of what to look out for and know that this one is considered a medical emergency and definitely needs follow-up. So you have kind of the full picture of what those disorders are. Are there any questions specific to that before I move forward? And you'll have some space at the end as well to ask questions, but I wanted to make sure everybody kind of understands what's what in terms of what we're looking for. All right. So we'll go on. So where do these things come from? Why does this happen? There is evidence that these disorders happen more often to women in the childbearing period than at any other time in life. So there is something about this period as to why it's happening. So there are a variety of risk factors and things kind of at play. We'll just look at some different items here. The most important one to pay attention to is anybody with previous history of these perinatal mood and anxiety disorders. So if you're working with someone who is pregnant or thinking about getting pregnant for a second or third time, then it would be important to find out, did you have previous experience with any kind of postpartum anxiety, depression, anything like that during pregnancy the first time or afterward? Because that's going to be more likely to repeat itself. It could also be paying attention to just history in family. So if this person's mother or sister or somebody else also had those kinds of issues, then we just want to keep an eye out. just any history of mood and anxiety disorders. So maybe not during the perinatal period, but say I'm pregnant and I'm, 25, but I had some serious depression in high school, then we want to pay attention to that. And it could pop up again. So it's important to kind of get a good history for people in terms of their background with any kind of mood or anxiety disorder. Also, people who've had a history of really strong reactions to hormonal changes. So we definitely think that there's some kind of biological component to this, of hormonal shifts that might trigger it. And so if somebody had a particularly challenging time during puberty, or has significant mood swings with their period, or significant reactions when taking some kind of hormonal birth control, then that would be something that is important to pay attention to, because they may be at greater risk as well. As well as those who have any kind of endocrine problem, maybe that's causing diabetes, thyroid problems, fertility problems, like any kind of endocrine issue may also predict that we have more risk. So these things do not mean that you will have these problems, but they're just things to pay attention to, because the more of these boxes that you check, the more likely you might be to have this problem postpartum. There are a ton of social kind of impacts or risk factors as well. So lack of partner support or other social support. I don't know exactly who you all work with in your agency, but I imagine that you find people at times who don't have family support. This happens everywhere, right? People who maybe don't have family support, or people who don't have a partner who's on board or supportive or helpful. And so that can be, I think, a very, very large predictor of some kind of perinatal mood or anxiety disorder. They're on their own, right? They don't have these people to help out, even with really small things, like making sure that somebody else is helping have food on the table, things like that. So that's a really important one to pay attention to, and one that, like, while we can't make somebody's partner great, we can look at social support and how to increase that a little bit during pregnancy. Financial stress and poverty, unfortunately, exacerbates many problems. And so this is not an exception. So that's something to pay attention to. A recent loss or move. We talk about how it takes a village to raise a child. And so if a family has moved recently, if a woman has moved, if she's on her own, then she maybe doesn't have, again, that social support that would be really important. And then we find it more often with other kinds of loss or grieving. Some people have lost a family member recently or something like that. And so that might kind of trigger or set off some kind of different reaction. So that's important to pay attention to. Military families, unfortunately, have a higher incidence. And so that is something that we want to notice and figure out better ways to serve, the men and women in those situations that maybe have a partner who's deployed for a long period of time, or different things like that kind of increase. And again, military families we often find have moved, relocated more often. And so that is an added stress as well. Unfortunately, we find that teen parents are just incredibly more likely to have a PMAD. So you can see there in the study that I've listed here, 28 to 59%. So again, depending on where the cutoffs are, 28 to 59%, some people just generally agree on about half of teenagers who become pregnant will experience a mood or anxiety disorder. And so that's really high. And obviously teenagers too are probably going to be lacking in some of that understanding social support if they don't have a lot of people who are kind of in a similar situation that they're in. So we absolutely want to be paying attention to any teenagers that show up pregnant, because their incidence of having one of these disorders is just very, very high. Parents of multiples, anybody out there have twins, triplets, quadruplets? I do not, which is great. It made things a lot easier. I remember initially I was like, well, it'd be great. Just go ahead and have a couple at a time. Then you only get pregnant once, but you got siblings. That's just not how it works. And it's really, really hard. So a lot of times when we see people who have multiples, there's just a higher rate of having a postpartum disorder, because it's a lot of work. It's a lot of stress. Also single parents, again, if we don't have help, then it's just a lot. So I'm impressed by everyone who does it on their own. We definitely want to come alongside anybody who's doing it by themselves, because it's an incredible amount of work and a lot of stress. And so again, your risk goes up. Here's just a whole list of other things. So there are quite a few risk factors, and just these I listed as kind of exacerbating factors. They're just a little extra, just things that kind of push you over the edge. Physical pain. So some people obviously have a lot of physical pain following birth just because various things have happened to their body during that process or during pregnancy. And so that's something to pay attention to if it's hard to move around and things like that. Lack of sleep, there's not a person who's going to have a child who's not going to have some lack of sleep. And so that's just something that's going to always happen. We can't do a ton about preventing, but it's something to really pay attention to, because one of the biggest things we do in treatment for postpartum mood anxiety is to get the person to sleep. So if somebody comes to me, the very first thing I'm doing is finding out how much do you sleep and how can we get you to sleep. So it may be that you go stay at a friend's house for a night and sleep. I mean, some of these things are a little different with COVID, but it's like you're gonna like let someone else feed your baby for the night so that you can get one night's sleep. Because some people feel like a brand new person with just one night of sleep that's uninterrupted. Abrupt changes in breastfeeding can be problematic. And that's just, again, it probably relates to those hormonal shifts, but any kind of really quick change there can be problematic. Not having childcare, obviously that's difficult. I think that's probably something that has exacerbated things for a lot of people in this pandemic, because people have many fewer options possibly for childcare. Some people have no options that they feel comfortable with for childcare. And so that would make it much more likely to experience one of these disorders. Again, relationship stress, any kind of loss, miscarriage, abortion, stillbirth, like any kind of loss or grieving is going to be challenging. Complications in birth, again, that would go back to increasing your risk of postpartum traumatic stress, but it could contribute to depression or anything else like that. And so I see a lot of that in my practice. Maybe they present with anxiety or depression and not necessarily a PTSD kind of thing, but they have some birth complications that they really want to sort through. Difficulties breastfeeding. So some people put a lot of pressure on themselves to be able to breastfeed, or they're getting outside pressure to be able to breastfeed. And so then if one is not able to do that, there can be a strong sense of failure, which can definitely contribute to these kind of disorders. And so one thing you're doing, if any of you all are working with women who are attempting to breastfeed, you can just be really supportive, right? That it is a wonderful thing. And also it's okay, as long as your baby gets fed, you can be very supportive of their choices and abilities, and to try to provide support to make something happen if that's their goal, but to make sure they understand that they are an okay person if it doesn't work out for them. Any kind of health problems, so babies who are particularly sick, or if you have a parent or partner with a lot of illness, that's going to be a problem. Babies with difficult temperament, so it's a little bit hard. We don't want to blame the baby, but I think everybody is aware that some babies come out a little easier than other babies. I got one of those easy babies, but I like to take all the credit for him being a great sleeper and making our lives like pretty easy that first year. But really a lot of that was kind of how he came into this world. And so we didn't have to adjust a great deal to our expectations of how to soothe him, how to help him. So I'm sure many of you here in this chat have had children, have seen children who are more difficult to soothe. And so that can be tough. There can be babies who are kind of crying for a very long time for no reason. And you've tried all the things and you're a great parent, and yet they're having a bad day. And so the more that's happening, the more likely a parent is going to question themselves and kind of fall into this maybe depressed state. Perfectionism plays a big role. So again, there are a lot of pressures to choose the right bottle, breastfeed, to make sure you're using the right clothes, feeding them well. There are a lot of opinions, a lot of stuff flown around. And so if a person already kind of struggles with perfectionism, it's going to be tough. Difficult relationships between the parents and their parents can definitely signal problems. Sometimes people just have unresolved issues, which it sounds kind of cliche from a therapist to say we have unresolved issues with our mother or with our father, and that's why, but it happens. A history of physical or sexual abuse in the past, and then unplanned or unwanted pregnancy. So I think it holds true. You all probably know a lot about it in your work, but about half of pregnancies are not planned. And so there can be a lot of surprises with that, and that can raise our risks as well. So that is kind of a big list that's not necessarily fully exhaustive of all these different things that can contribute. Those are all things you can look for. Other things that are kind of important to pay attention to, I've been mostly referencing the moms, but fathers, partners, non-gestational parents can all also experience PMADS. So it's not just a mother who's giving birth. So a lot of the research is more on like a father, a male dad, showing the prevalence around 10%. So more research is needed for all these other populations that may be involved. But I think too, for your context, we want to notice for sure that adoptive parents also experience PMADS, and we don't want them to get left out. So if we think of postpartum depression as only a biological problem, then we're only paying attention to biological mom. But we want to make sure we pay attention to any partner or any adoptive parent as well. Especially adoptive mothers seem to experience PMADS. So it's good to screen everybody, not just somebody who gave birth. But that said, too, birth moms who have placed a child for adoption may be overlooked. And so we definitely want to follow up with any birth mom who is placing her child. So it's not just the burden of caring for a child that creates these mood and anxiety disorders. It's more complicated than that. So just because birth mom doesn't have her child doesn't mean that obviously that she may not have some impact from these, but she may be isolated, she may be overlooked, she may not get follow-up care. You know, a birth mom who has placed a child for adoption may not be attending a support group for other moms who have their children, right? So we want to make sure, and you all probably have some more resources that you can let me know about if you do, through your organization, for places for women to go if they have placed their children for adoption. And I know that Postpartum Support International does offer a group for mothers who have placed their children for adoption so that they have a space to kind of talk. But it's important too, as we move into talking about screening, we want to screen all of these groups. So we don't want to only screen the biological mom who took her kid home. But we want to pay attention to everybody in that bubble. So any questions about risk factors? All right.
I'm not seeing any questions.
Oh, I'm sorry. I have a question. It's Nancy.
Yeah.
So can you, what the name of that site again? Was it Postpartum International?
Yeah, it's called Postpartum Support International. And I'll share a little bit more at the end with some resources, but I did notice that they specifically had a group for mothers who placed children. And they have a lot of different support groups. So we'll kind of hit that at the very end with some other resources.
Great, yeah. Thank you.
And their actual website is postpartum.net. And I think I put the actual website later, but if not, we'll Google it, or I'll make sure to email everybody later. But yeah, that's a good question. All right, so all that is kind of background information. And what I really hope you all will take away from this is that we need to be screening for symptoms. We need to find out who is experiencing these disorders so that we can do something about it. So, you know, why would we bother screening? Well, as I've said, it's a very common problem. And so we're not doing some huge invasive exam on something that happens to 1% of people. We're doing a very easy kind of screen that's really cost effective and can identify a problem that's pretty prevalent. So I think it's important to do it because it is incredibly common and it's not that hard to look for. Treatment is very effective. So that's kind of the cool thing, is most people get better, which is not the case with every complication that we find or every mental health problem that we find. But most people that have this thing pop up in pregnancy or postpartum, like, get better. And so that's really exciting. And so they don't get better if they don't get help. And it can get worse. It can carry on. It can have a lot of long-term costs. But gosh, if we notice, if we find people, if we get them into treatment, they get a lot better. So, excuse me. So they often too will go undetected if we don't do a formal screening. So we cannot expect a mom to show up and say, hey, I feel terrible. Hey, I feel like I'm going to kill my baby. Like, most moms are not going to just come to you and tell you that. They might, some of them will, which is excellent, but many of them will not. Because they have all kinds of reasons, right? But most of us, we want to be perceived as competent, capable, okay. And we have this pressure on moms to be great, to be really excited, to be happy to be a mom. This is the best time of their life, right? And so it's going to be really hard for her to tell you, like, actually, no, like, I feel terrible and I wake up crying and I, you know, really am unsure if this is what I want for my life, or I feel so anxious and worried, like I haven't slept in 3 days. I stare at my baby while she sleeps. I'm so worried that she's going to suffocate, right? A lot of times moms won't tell you that. And so we want to do a formal screening. We want to pay attention and we want to really ask the questions so that things don't go unnoticed. A lot of these disorders too, because mom feels so bad internally, she may present as looking really good. you know, if I feel really depressed and terrible and awful and like a bad mom, and I do decide to maybe seek treatment or just go to the doctor's office, I'm going to look put together because I don't want them to know. I don't want them to find out that I'm a fraud, that I'm a bad mom, right? We also have a lot of moms that, you know, they're just, I can't remember what I was gonna say about that, but basically we're going to see people hiding it, right? We're going to see people who are unsure. Oh, I was going to say that, you know, a lot of people, when their baby is initially born, they'll describe this great sense of connection with that child, but that doesn't happen all the time. So you'll have women who have birthed a child, not felt any kind of rush, and immediately sort of feel like a bad parent, don't know how to share that. It kind of snowballs. So again, because people are going to hide so much of it because there's shame, then we may need to ask the question. So coming to training like this, talking about it a little bit more can normalize that conversation. So that's kind of my last point on this slide, that if we'll talk about it a little more, then we may start to see more moms coming and saying, I don't feel good. You know, that thing we talked about when I was pregnant, now I'm seeing it, right? I never thought it would happen to me, but you guys talked with me about it. Now I'm seeing it. I need help, right? So the more we screen, the more we talk about it, the more we raise awareness, like the more likely we are to catch more people who are experiencing this. And again, the earlier we do it, the better the outcomes. So I'm hopeful that you all will all take this part away, even if you don't specialize in this treatment, or if it's not something that happens to you day to day, but that if you're in a role interacting with a new parent, a pregnant person, that you are able to screen. So I will talk to you a little bit about kind of how to do it, what it will look like. Anybody can do it who is encountering a person who is pregnant, or a person who has given birth, or a person who is adopted. Like any of you all that interact with people can do screening. You do not have to be a mental health professional. You're not diagnosing a person. And so anybody can do it. You just want to create some comfort and privacy. You're not, you know, yelling all these out in a waiting room out loud in front of people. You just make it comfortable for people. It's really good to just let people know, hey, we screen everybody. So that's helpful. So it's not like, you looked like a bad mom, so I'm giving you a screening. We don't want to do that, right? So we want to just universally screen, because we don't need to be picking and choosing who we think might be feeling this way or not. Again, it can be really hidden. So just let them know, hey, we screen everybody at these times. And we do it because we want to help. There are guidelines from the pediatric groups, from the gynecologist groups, that tell you how often to screen. So if you have a professional organization, you may want to check into what their recommendations are. If you're not already doing that, if you're a physician, nurse, whatever you do, you may have a group that tells you how often to do it. But good guidelines to follow that I've listed here, it's really often, right? So we want to do it the very first time we meet somebody for a prenatal visit. Sometime during the second trimester, sometime during the third trimester. You can do it at the 6-week postpartum follow-up visit. And you also want to do it at 6 and 12 months. So some people are screening up to that 6-week visit, but then we're leaving out the rest of that first year. And so we want to pay attention. So another great place to catch that is at the child's well visits, that 3 months, 9 months, 12 months would be a recommendation. So you can't really screen too much. So if you're thinking, well, they probably got screened at this other appointment they went to, well, that's fine, but you can go ahead and do it at yours. Don't worry about kind of overdoing it, but this is just a guideline of how often it should probably be happening. And if you're seeing these people multiple times, then you'll even kind of be able to compare and think, wow, it shifted. Maybe it's getting better or getting worse. There are several tools available, so I will tell you about a few different ones. And then we'll kind of focus on this first one, the Edinburgh Postnatal Depression Scale, the EPDS for short. We can look at the postpartum depression screening scale and the patient health questionnaires, which are not specific to postpartum or pregnancy. So we'll kind of go through each one of those. The best part about the Edinburgh Postnatal Depression Scale is that it is free. And so that's why I'm going to focus on this one. It's free, it's widely used, very accessible. You can find multiple different versions of it online in terms of just how it's been formatted. But it's been well validated with many, many different populations. And it can be used during pregnancy and postpartum. So it's not postpartum only, but it's something you could be using for this person consistently throughout pregnancy and afterward. It's very easy. It's just 10 questions and it's available in over 60 languages. And so it's great to be able to do this scale in the language that someone speaks in their native language, because it's going to be easier for them to kind of connect with it and give accurate answers. So I think that's a great reason to use this one. The postpartum depression screening scale is also lovely. It is only for postpartum use, so it would not be one that you'd be using for pregnancy, and it comes in English and Spanish. So if that's your population, then you've got it covered. You just wouldn't have as much variety of language. And it is more thorough. So it takes about 5 to 10 minutes. So it being more thorough can be good. But if you're looking to just get it done quick, then it's maybe going to take a little bit more if you don't have that amount of time. But it also assesses some risk factors. So if you're really doing a really thorough treatment option, this could be a good one to look into, because you'll be able to assess some risk factors and maybe intervene, even if they're not signifying that they have a lot of symptoms at that time. And it is just written for a 3rd grade reading level. So hopefully that makes it more accessible for more people, which is good. It is not free. It's also not super expensive. So I looked it up before this training, and it might be a couple dollars per screen. So you would buy a big pack, and they're maybe $50, $100, and have several copies in it. But if you're working on a bulk scale, it's going to add up. So if you're buying a pack of 25 for $50 and you don't see a ton of people, great. But the cost could add up. So that could be the only reason that that one may be less effective for your particular context. The PHQ-9 and PHQ-2 may be more familiar to doctors. They're just commonly used in medical practices and things like that. It's not specific to the perinatal period, but it'd still be a fine one to use. They're specifically more looking at the diagnostic criteria in the DSM, which is what is used for depression diagnoses most commonly. So again, not perinatal specific, but could still be better than not using anything. It is also free and also available in a lot of languages. So definitely it would be worth checking out as well. The PHQ-2 is just only 2 questions. So it's better to do a little bit longer. I mean, a non-question scale versus a 2-question scale, non is not going to take you that much longer. So I would recommend doing non over 2, but doing 2 is better than doing nothing. So again, if your context prevents you from spending much time, then you might do just a couple questions. Or if your context already includes these kinds of screenings in your office materials and things, then you might look into that one, the PHQ. That one, again, is free and online. So here are the websites, excuse me, I'm looking for my water, for all of the options. So the EPDS, again, you can find a lot of those. If you just Google the Edinburgh Postnatal Depression Scale, you'll find various options, and some have more description with them. Some are formatted differently. Some have the number scoring, which we'll look at in a minute, on the page, and some of them don't. So you could just choose whichever one you have a personal preference for. The one that I've listed here is the one that I'll show you in the slides in just a moment. The PDSS can be found there, and that's where you can purchase it. And so check that out if you're interested. And then the PHQ, again, is located there at the website listed, and there are many variations of that. They also have some anxiety scales and things like that on the PHQ website. So if you're just a person who loves surveys, check it out. But those are all some good resources for y'all. And you'll have, I think, access to these slides when we're done. So to use the EPDS, if that's the one that you choose to use, again, it's only 10 questions, so it's not going to take you very long. If you are a medical doctor, there are billing codes for these kinds of screenings. I can't tell you what they are because that is not my job to do those. I don't mean it's not my job to tell you, but I just don't know what they are, and I have not taken the time to look it up. So we can figure that out together if you guys need help, but it's really quick. So it can be self-administered. So if you're in a situation where people are spending time in a waiting room or lobby, or sitting at home waiting on their Zoom call, however you're doing on your treatment now, it can be self-administered. They can fill out the survey by themselves. So if you're limited on time, you can have them do that. But again, just make sure that they have kind of privacy and space to do it. It's best for the person to fill it out for themselves. So you don't necessarily want a partner to fill it out for them, because their partner may not really see what's going on internally. So it's best practice is to have the person fill it out for him or herself. Typically, a score of greater than 10 would signal the presence of depressive symptoms. So again, it's just looking at the presence of symptoms. It cannot tell you severity. And so if you meet a person and they score a 12, then yeah, they definitely probably have some depressive symptoms. Whether those are mild or severe will take a little bit further evaluation, but it would tell you enough information like we should make a referral. It's probably a good idea. Cutoffs may vary with different cultures or ethnic groups. I think I have some specific details on that a little bit later, so I won't hit that just yet maybe. But typically 10 means a positive result, and we want to move on to treatment options. But you can use your judgment, and if they got 9 and you think we should probably, then go ahead. That's going to be fine. So here's the example of the Edinburgh that I pulled off on. And again, this particular place just has people put the date, their age, kind of how old baby is, or how far along they are in pregnancy. And here are some examples, or well, not examples, these are all the questions that I've been able to laugh and see the funny side of things. I have looked forward with enjoyment to things. I have blamed myself unnecessarily when things went wrong. I have been anxious or worried for no good reason. I have felt scared or panicky for no good reason. Things have been getting to me. Again, with all these, they're rating yes, most of the time, some of the time, not very often, or never. Those variations of those results or answers. I've been so unhappy. I've had difficulty sleeping. I have felt sad or miserable. I have been so unhappy that I have been crying. The thought of harming myself has occurred to me. So those are the 10 items. And again, they're answering with things like yes, often, sometimes, hardly ever, occasionally, things like that. And then each of those is given a point value. So I don't know how much you can see on that right now, but some are 0, 1, 2, or 3 points. So you literally just add it up. So if you get one of these that has the points already on it, then that's easy for you because you can just kind of go through and add it up, right? And if you get more than 10, then that's a positive screen. All right. The important thing to keep in mind here is that that last one is about self-harm, harming themselves. If there's any answer that's not 0, then we need to follow up right then. So if they're saying, yes, I've considered hurting myself, then we don't want to say, well, call a therapist and you can talk to him or her, you know, they might get in 3 weeks. That's something we want to follow up on right then. No matter who you are, you can follow up on suicide risk. You just want to ask more questions like, okay, well, tell me more about that one. Definitely you want to make sure that's in a non-judgmental way. There's an app that you can use. So SAMHSA has a suicide safe mobile app. So if you're thinking like, I have never done suicide screens, nor do I want to, which is honestly why some people don't want to screen at all for these things, because we just don't want to find out the answer to somebody being suicidal. But this app will like just work you through it. And here are the 5 parts of their kind of safety plan. Identifying the risk factors, identify protective factors, conduct a suicide inquiry, determine the risk level and intervention, and then document. For the purposes of our time today, I won't go into detail about all of those things, but you can read a little bit more about it on the SAMHSA website. If you'd like to, or you can download the app, it'll kind of walk you through a little bit more about what would put somebody at risk, what questions should I ask, just to decide if it's an emergency or not. So you're finding out more about their plans and things like that. So sometimes it's emergency and sometimes it's not. At that point, you definitely still want to make referrals and follow up. So that's a key, is we can't just screen people and say like, well, you seem like you might be depressed. You should probably call a therapist. Here's a list, and leave it completely up to them. We want to maybe call and follow up at some point and make sure that they did follow through, especially with suicide risk. So some things to consider from a cultural perspective is we don't want to make assumptions. People are going to come work with you all from all kinds of different backgrounds, all kinds of different cultures, races, ethnicities. So we don't want to make assumptions about who they are, about their process toward becoming a parent or toward placing a child for adoption. We want to kind of take that not knowing stance, learn about that person, about what they're about, find out more about views, values, beliefs, any coping practices in their culture that is, seen as normal, acceptable. Learn about customs around childbirth in different cultures, different expectations of family transition. Some people come from an expectation of mom does everything by herself. Some come from like ton of support pops up and mom gets to relax and care for herself after birth. So we want to learn a little bit more about that where you can. And mostly for the cases of the purposes of this talk is use caution when you're interpreting scoring and screening. Not everybody's going to answer the same way on that or the way that we might expect. And so again, we want to use our judgment and not rule somebody out because they don't hit exactly that 10 that we expected or didn't describe the symptoms exactly as we expected. Some cultures may talk more about mood and some may talk more about their body and may feel things more in their stomach or in headaches and things like that. So we want to pay attention if they're describing things a little bit more in their body. Specifically, there's a little bit of research on screening Black and Latina mothers who may have been less likely to express some feelings of depression or anxiety, but then they found with these Black mothers that actual prevalence was higher than white counterparts. So there was less disclosure of it, but actually more prevalence. And so that could easily be missed in screening. There was also some findings that these women were waiting longer between maybe having symptoms and seeking treatment. So there are definitely some disparities. I think if we spent a lot more time here today, we could talk much more about disparities in healthcare for minority populations, specifically Black Latina mothers. Like, that's not the purpose of our talk today, but you want to pay attention if you're screening that you might want to have a lower cutoff score. So in the study that's cited here at the end, they recommended a 7 or an 8 versus a 10. So if this person fills out the EPDS and has 7 or has 8 points, then that would qualify as a positive screen worthy of paying attention to and referring, rather than maybe a white counterpart getting a 10. So that would be more equivalent. So I think obviously that's something that's really important as we're screening people from all different backgrounds, that we're sensitive to maybe the ways that we report our symptoms versus keeping them to ourselves, and make sure that we don't miss people. All right, so that brings us to referring to treatment. Were there any specific questions about how to screen before we talk about what to do or how to refer?
I'm not seeing any questions, Lindsay, but people did like your assessments. Thank you for those tools. That's excellent.
Good. Yeah, I hope those are helpful. They're just really easy to use, and so I think a lot of people maybe even have an awareness that these problems are out there, but just don't know exactly where to find the tools, how to ask. And so it's nice to just have a sheet that's like, hey, fill this out, talk to me about what's going on.
Yes, so, I especially appreciated what to do after you assess them. I mean, I think that's where things can get kind of hung up sometimes.
Yeah, absolutely. So I'll give a few ideas about kind of how to refer moving forward. So if you do get a 10 or if you get a 7 and you think, yeah, we should probably do something about this, we should follow up, then these are some ideas about referring. So I work with Postpartum Support International and serve on the board of the Tennessee state chapter. And so Postpartum Support International is a great organization that, formed initially more out of a network of peer support. And so they really value and believe in the benefits of peer support groups. So other women who've been through the same situation, kind of getting together and supporting, encouraging one another, hearing from each other. And so they exist, have a ton of resources. They primarily want to educate and inform providers as well as new families about what's going on, what to expect, and then how to get treatment and try to connect people with treatment. So I serve on the Tennessee state chapter board. So wherever you all are located probably has a state chapter. They're kind of growing. But their big motto, the thing they say over and over and over, you are not alone, you are not to blame, and with help, you will be well. And so I think this is really key to share with anybody that you're screening. If you get that positive screen, you can let these people know, like, you are not alone. This is incredibly common. There's nothing wrong with you. And you are not to blame. You didn't bring this on yourself. You didn't create this problem. Again, it's very common. And with help, you will be well. So there is treatment available. So, it would be kind of worthless to screen if we said, yeah, you feel bad. Well, I'll see you next week. That wouldn't be worth your time to screen, but since we can't offer helpful treatment, we want to make sure to screen and to let people know, like, hey, yeah, this shows that you have some depression symptoms. This shows that you have some anxiety symptoms. Like, you're not alone. It's common. It happens to 1 in 7 women. It's not your fault. And with treatment, you're going to feel a lot more like yourself. And so that is really key. So if you're not sure where to start, that's a great place to start. It is important to recognize emergencies. I'll just repeat this. I said it earlier, but we do want to notice when it's an emergency. So anybody who has an active plan for suicide, we need to go ahead and call a suicide hotline, call 911. You need to make sure that they're directly taken to the emergency room with a family member or something like that. So mania can also be an emergency. Psychosis is definitely an emergency, and suicide serious suicide risk. So if someone's generally been thinking again of like, well, I kind of wish that I could fall asleep and not wake up, that may not be an emergency. We definitely want to refer to treatment. But if they have a suicide plan, if they're psychotic, if they are manic, then that is a time to intervene and make sure they are looked after and cared for. Other times we can be a little more, have a little more time to plan a good referral connection. So options for treatment, you want to think about psychotherapy first and foremost, can be really, really important. I mean, selfishly, I'm a therapist, so I think that that's where we should send people. But talk therapy is really effective. I am not a cognitive behavioral therapist, but it's incredibly effective with new moms. So if that's your jam and you love CBT, then get some training in specific interventions for postpartum women, and it's really helpful. Some interpersonal therapy is helpful. Just various versions are really beneficial. So psychotherapy, number one, super important. Medication is very, very helpful during this time. So I'm not one to always send clients to get medication for everything that they come in to deal with, but medication is very helpful in postpartum and pregnancy. And so a lot of people are hesitant to take medication while pregnant or medication if they're breastfeeding. But there are many safe options. With a trained provider, they can really help you understand the risks and benefits to treatment versus non-treatment. I partner with a psychiatrist here who has a specialty in perinatal mood and anxiety disorders. And she was just talking yesterday about doing pre-pregnancy consultations. And so that's an option a lot of people aren't even aware of. Again, you all are probably more seeing people show up when they're already pregnant, but if anybody's talking about a second pregnancy or if you just know people in your life who are kind of wanting to actually plan a pregnancy versus an unplanned pregnancy, then talking to a specialist about what medications are safe for me to take is beneficial. So if somebody's already has a mental health diagnosis or is already taking medication, then it's really important to kind of keep that going. And there are a few times where those need to be changed. But again, we want to work with a specialist who really knows what is safe and not safe to take. We don't actually have to stop taking everything to get pregnant. So again, medication is just magical how somebody can feel terrible. They sleep for 3 nights, they're a new person, or they sleep for 3 nights, they start to feel a little bit better. They start taking a little bit of an antidepressant, and a month later, they're like, wow, that's weird that I felt so bad, right? So, having a great person to refer to for a medication evaluation is helpful. Personally, I'm so lucky that I have a psychiatrist here with a lot of training and experience in that population. You may not have people who are specialists. You can start with their OBGYN. Many of them are comfortable prescribing things like Zoloft and things to get people started and see where it goes. So that is a great first line. Often that woman is going to be comfortable already going to see that person. And so that's not going to be a problem for them to go back, assuming there wasn't like a traumatic birth experience. So that is a great place to start to develop that relationship. If those people are not interested in prescribing because of questions about breastfeeding or pregnancy, then there are resources that they can consult. And so I'll tell you at the end, or I can tell you now too, but there is a psychiatrist hotline that you can call and speak to a psychiatrist through Postpartum Support International. So that's a consultation just for medical providers. So it's not something that I call as a therapist, but if I were a medical doctor and I wasn't sure about prescribing a medication, I can call that hotline and talk specifically to a perinatal specialist. So that's a really cool option that is out there. So again, psychotherapy, super helpful. Medication is very helpful. And the combination of those two is often the ticket to getting better. Some people want to try therapy for a while first before medication. I think that's great. And then we can add medication if the therapy isn't helpful. But definitely, I think the therapy is helpful. There's usually a lot to kind of process and dig up. It's not usually just let me take some medicine and everything will sort itself out. But some treatment is better than none. But it's interesting when we can get enough treatment, that's when we really get better. We don't really want suboptimal results because we've treated a little bit under the threshold. So refer to psychotherapy, refer to medication evaluation. Peer support groups, if you have access to any of those, like I said, are really beneficial. Now, because of COVID, everything's online, which is really cool because there may not have been something in your area, but now you may be able to refer to something that has moved online, which might be a really great option. And you want to be able to possibly just build some family and social support. So if you're noticing like, hey, this mom is having a hard time, Can I talk with her caregivers about like giving her a night off? Can we talk about getting a meal train going? Can we talk about just her having some friends drop by regularly to check in? You know, there may be some things like that that would really boost things as well. So if it's going to take a week or two to get into therapy or to get into some medication, places you can start are eat, sleep, and exercise. And so if you can figure out how to build that family and social support to help this person get a little exercise, get a little sleep, get a little food, drink some water, then that actually does wonders. So sometimes I'm really out of a job with these moms, because if they can just sleep for a few nights and then people kind of start pitching in or helping out a little bit, they're like, oh, I feel a lot better. I'm like, great. So that's a cool option that you can kind of work on as you're getting them into some kind of treatment. Some things you can do to be helpful with the referral process are to remember that not every therapist or medical provider is the right fit. So every time I meet a new client, whether they're postpartum women or just, you know, whoever, I let them know, like, we may not be the right match. You know, I have my own training background, personality, etc., and it may not fit with you, and that's okay. That doesn't mean anything's wrong with you. It doesn't mean that you can't get better, but I may not be the person that will help you with that. And so you can let a mom that you encounter, a dad that you encounter, whoever you're working with, know that, hey, these are a list of people to call. Your first call may not be the right fit. So if you don't feel comfortable, if it doesn't feel like the right fit for you, like, let's keep looking, right? Let's find the right fit for you. If you go to a medical provider and you feel dismissed, let's find somebody else. Like, there are other people that might be possibilities. So let them know that that is okay. You want to find out about their ability to pay or use insurance benefits. It's not going to be very useful for you to refer people to a clinic that they don't qualify for, or to refer people to a private practice therapist who takes cash and does not have reduced fees if they don't have the ability to pay. So make sure that you have an understanding of their financial situation or any insurance that they might have, and actually give referrals that are useful. That postpartum mom is not at her best. She, you know, even if she's not experiencing a mood disorder, it's a really hard time period. She doesn't want to make 20 phone calls that are dead ends to people who don't take her insurance, you know. So the better resources you can have, or the better understanding you can have of what she can actually afford, will be helpful to you. Evaluate that client support and resources. Again, this goes along with what I just said, to kind of make sure that they are in line with the services you're recommending. So if you have a person who doesn't have transportation, then we don't need to refer her to something that is not close to public transit, you know. So pay attention and just make sure that the referrals are appropriate or relevant to that client, or help them get those resources, help them get over that hump of like, okay, here's how we can solve the transportation problem to get you to this therapist that can be helpful. Make sure that we cover both bases and don't leave that out. So we just want realistic treatment options, right? We don't want to refer someone to an online group therapy if they just have like a cracked screen phone and no internet. That's not going to be helpful. We want to make sure, again, that we can provide a space for that to actually work and be beneficial. If you can, it's best to look for professionals with training in perinatal mood and anxiety disorders. It can just be helpful to have that differential diagnosis ability that they may have, to have more familiarity with, you know, if a postpartum obsessive compulsive mom comes in and says, you know, I had all these thoughts of hurting my baby. It's really great for that person to be like, oh yeah, that can happen. Tell me more about that, you know, and that they can reassure her that like, those are just thoughts and you're going to be okay. Right. So we want to, you're going to have a higher incidence of success with people with specific training. That doesn't mean that other people aren't great therapists, that they don't care about their clients. But it will be useful if you can find some people with some extra training in that area, then that was more likely to be successful. There is a provider directory available at postpartum.net. So again, that's Postpartum Support International's website. There's a provider directory. I don't know how many people have signed themselves up for it. I think you can find people in most areas. You may or may not. So check it out. If you're having trouble, let me know. Because there are a lot of local, what we're working on is trying to make this network really work, right? So that there aren't a bunch of resources that people don't know about, but that we can go to one place and kind of find them all. I think that's a big goal of postpartum support. You want to consider facilitating contact with the provider. So as a therapist, I in general think if somebody doesn't want to call me for therapy, I'm not that interested in working with them. Like, I want them to take a little ownership and a little effort into getting that started. But for this particular population, I think it's really useful for someone else to help with that. You know, like I said, if you've just had a baby and you're not feeling well, like, it's hard to make all those extra phone calls and try to get things set up. So feel free to help, to sit there while they do it, to even just give them 10 minutes in your space to make those phone calls they need to make, because they might not have any other quiet time in their day. So feel free to kind of step over what might be your normal boundary of like facilitating contact with providers. And everybody has different boundaries. I don't know. As a marriage and family therapist, I feel like mine are a little more like, I'm me and you're you, and I don't like help with case management kind of things. But I think this is a space where that is more helpful. Make sure you give multiple referrals. You don't want to give one or two and then they call and those people are full and they don't know what else to do. So it's helpful if you can give people a few so they have some choice in the matter, and follow up. So, you know, you got to check in with them. And there are people sometimes I talk to, and every week I'm like, so did you do that thing? No. Okay. But I'm going to keep checking in. You know, did you call? Did you call? And, you know, sometimes a month later, they finally go and they get their medication evaluated and they start to feel better. So we just want to keep following up, even if they have to keep telling us no. We want to make sure that they have all the resources and that we stuck with them even when it was hard for them to do the thing that they knew they needed to do. So stick with them, follow up, be a help in making those calls if you want to. You can think broadly about support options in your area and develop relationships in your community with anybody that has any connection to birthing, anything to do with pregnancy, postpartum, early childcare, things like that. So these are just a few ideas. You all might have more, but birth doulas, postpartum doulas are kind of a magical gift. If you're not aware of what they do, they'll come into your home after you have a baby. Help take care of the baby. They can do, some of them do like light laundry or really simple meal prep, like making sandwiches, stuff like that. Like, they're not going to come in and make you a lasagna. Probably some might add that to their service, but that's beyond the call of a postpartum doula. But they can just help with a lot of really simple tasks and make things easier for you. So they can, you know, just watch baby while mom takes a shower, things like that, things that can be difficult if mom is not able to have another person in the home who can be there, or maybe their other person is there, but not all that helpful. So a postpartum doula is really there to look out for mom and can assist usually with like breastfeeding issues and things like that as well. So that's a great thing. If you don't know any in your area, try to get connected with some. I don't know what they're all doing with COVID, if some are going to homes, if some are not, if some are just checking in virtually, but they're just a person who's there just like a birth doula to really advocate for the mom and what mom needs. Whereas other people are just paying attention to baby usually. It's really fascinating. I remember I had a fun, safe birth experience. It was long and it was difficult, but it was fine. But I remember afterward, you know, everybody just wanted to see my baby and I was so hungry. You know, I had not eaten in like 2 days, 3 days. They wouldn't let me eat while I was there in labor. I was so hungry. And I thought, this is how it's going to be, right? For like the rest of my life, people are interested in my kid. They're no longer interested in me. And so that can be a hard thing. And so it's great if we can have like a doula sticking around. It doesn't have to be a professional doula. It can be just a family member, a friend, a partner who's looking out for mom. You know, I have a lot of women who come in and like after they give birth, it's like people just forgot about me. They weren't worried about me. They weren't paying attention to me, even sometimes to my medical needs, things like that. So think about these relationships that can be developed that can look out for your moms. Lactation specialists can be on that list, OBGYNs, midwives, therapists, physical therapists can be really useful. Having a physical therapist you can refer to if mamas are having some physical problems that don't resolve. Pediatricians, I think, are great because they interact a lot more with parents in the postpartum period than sometimes their medical providers do, massage therapists, etc. So there are a lot of people that possibly interact with your families, with these people that have given birth, these people that have adopted, like all these people interact with all kinds of different specialists and professionals during their time. And so these are people that you can both educate about looking out for these mamas. They also can be resources that you refer to these families of, hey, like this might be an area of support. This might be a place that can help you out. You know, you're physically having some trouble. Here's a physical therapist I know who's really sensitive to the needs of postpartum women. So this might be a good resource for you. Or, here's a postpartum doula and she comes for this process and she can come this often and here's what she might offer to you. Or you're having some difficulty with breastfeeding, like here's a great lactation specialist that's not going to pressure you, but is just really helpful and has good information. So these are all good relationships to develop. Does anybody have any that you'd want to add, or any that I have left out that you think are important or worth mentioning? All right. Here are some resources specifically from Postpartum Support International. So again, there are multiple organizations working in this area, but I think Postpartum Support International is pretty broadly recognized as just trying to connect resources to people. So they have a helpline that you can call anytime and leave a message and have somebody call you back that is in your local area. So the first call, I don't know if it's always a local person, but they will connect you to a local volunteer who is familiar with resources in your area. So people will call the PSI helpline, get connected to some of our coordinators in Tennessee, who will then be able to kind of consult the spreadsheets and things that we've been working to put together. And then they can send that person to someplace that can help them. And that way they can maybe pinpoint, here is a referral that takes your insurance, or here's somebody that has online support, or various things like that. They're able to provide those connections, which is really useful. So if you find a patient that needs a referral and you haven't yet developed a referral list of your own, then this would be a good option to kind of send that person to. They can call there and kind of get some ideas from there about where to go next. PSI does have online support groups and has been expanding those this year due to COVID. And so that's going to be a really beneficial resource, I think, long term. But they have various groups for different kinds of populations. So like I mentioned earlier, they do have one for birth moms who have placed children for adoption. They have groups for dads. They have groups for, I think the dads groups, I'm trying to remember if there's one that's specifically for dads who are actually suffering from postpartum depression or anxiety, or if it's just the dads who support partners who have that disorder. I can't recall. I think they might have both. They have some online chat things too that you can do. You can call in and talk to a professional once a week to kind of have questions answered. So again, that's a great place if when we finish here and you think, I have some more questions, or, 3 months ago, I mean, you can definitely email me about it as well. But that online, being able to call and ask questions, I think is a cool option. And then the website just generally has information. So you can kind of poke around there and find more information and more support, including the links to all of the support groups at postpartum.net. So I would recommend that. And then they have a psychiatric consult line for physicians, as I mentioned earlier. And again, that number is on their website. So that's a huge benefit. If you're a medical provider here today, then that's a great option to be able to call and talk to somebody who has a little bit more specialty in that area. So those are all resources that they have that I think are really helpful and useful. I can't remember. Oh yeah. And so kind of where to go from here, if you're thinking like, well, that was fine. What else should I do? If you got enough from here and you're thinking like, great, I understand now how to screen. I think I'll use the Edinburgh postnatal depression scale. I'm going to print it off. I'm going to use it. That's awesome. And that's what I hope that you can take from this, is that you have enough background knowledge that these disorders exist, that you'd be comfortable using that 10-question screener, that you would employ it often with anybody that you see, and that you would know kind of how to start the referral process for them. If you're more interested in actually doing some of the treatment for these people, for these families, then I would recommend going to one of the PSI 2-day trainings. Again, those are online now. Some are still, I don't know if they've canceled all the in-person ones this year. I imagine that they will. There will be ones in person in the future, I imagine, but currently the ones that have been scheduled online have all been transitioned, or in person have been transitioned throughout the year online, which is a great opportunity because you can get all the good information without paying for travel. Again, there are pros and cons. We were discussing before this started, it's nice to travel sometimes for CEs, but this will be a great time to do a 2-day training if it's not quite in the budget to visit another city. You can do it online. You can probably get scholarships from your PSI state chapter if they have not given them all out for this year. Every year as state chapters, we get a number of scholarships to give to people who are looking for training. So if any of y'all are in Tennessee, you can let me know. And we have scholarships available, but you'll need to get those from your state chapter. If your state doesn't have a chapter, I don't know if there are any from PSI as a whole, but I think we could find out. So that's an option to save a little bit of money on that. But the 2-day trainings are great. They're a much more expanded view of kind of what we did today, with a lot of extra information. And they are for therapists as well as any medical providers or just anybody interested. They're not specifically only for therapists or only for physicians. They're kind of for a broad range, a really good overview of anybody that's going to work with this population. They also provide PSI as a frontline provider training, which is specifically for healthcare workers. And so they say that that one is more for like nurses, doctors, midwives, like people that are going to encounter postpartum women, just to get them ready. Again, probably a lot of kind of similar things we talked about, like what can I notice, what can I be looking out for, and how can I make sure that I'm paying attention to that need in my practice. So the other thing you can do is develop some relationships in your community with providers. So you may not want this to be your specialty, but it's great to know other people who do and kind of send them that direction, and look for, again, those resources that you can send people. Find your PSI state chapter. Every state chapter is a little bit different. Some have been around for a little while and are doing great work. Some in Tennessee, we've kind of been running, coming up on 2 years next year, maybe the 3rd year. I can't remember, but it's like we're getting things moving, getting things working, and we'd love to have your involvement. And so your state chapter, I don't know what it looks like. Some have been around, like I said, a little bit longer and have more formal processes and programs and things in place. So again, if this really interests you, then that would be a great place to start, a good place to check in. So this is where to go from here. Do your screening. And then if you want more, check out a 2-day training, check out frontline training, work on those relationships in your community, and just kind of find out what resources are around wherever you are. So I'll wrap up from there. Here's a list of just some things if you want to check them out later, and I will let you all ask any questions if you have them. I'm happy to do that. So we have just a little bit of time left for that. But thank y'all so much for being here today. This is really something that is important to me, that I really enjoy being able to share, and have really enjoyed kind of adding that to my practice. And so I hope that it was some information that is going to be useful to you all.
Thank you so much, Lindsay. I've learned so much from you. That was extremely interesting, and I love your delivery too. It's so approachable. Thank you. Does anybody have any questions? I'm happy to take you off mute so you can ask them. Somebody just spoke up and said, thank you so much for the training. They really liked your resources.
Great.
Anybody else? Well, I just want to remind you guys to please register for your attendance for this training. The link to do that is in the chat. And if we have you registered, that's how we send your CEU certificate. But it's also, we'll be able to send you a survey so you can tell us how much you like the training and what topics you're looking for too. That's very helpful to us. We so appreciate you coming today, and I want to thank Lindsay again for her very wealth of information that she gave us, and for just being with us. If you guys have any questions about Gladney or our services, I invite you to reach out to us from the email that we send you for follow-up. We're happy to give you a tour or to do a virtual lunch and learn just to tell you about our services and how to refer to us. We're happy to be here for you in any capacity that you may need. And of course, keep coming back to Gladney University. We have a great lineup coming up, and I can't wait to see your faces again, or at least your names. Thank you, Lindsay, so much for being with us. And somebody else just said, thank you so much for the information. Will there be a recording sent out to reference? Yes, our recording will be on our Gladney University, our YouTube channel. And so please check back to Gladney University's YouTube channel where you can see all of our trainings that we have permission to record. Thank you so much, Lindsay. We'll see you later. Thank you all for coming.